This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
If you're thinking about your women's health program as a front door to building relationship with a key demographic that utilizes a lot of services and makes a lot of decisions, being deliberate about how you're going to engage with them is going to be critical as we're building out those programs.
Today, I get to speak with Karyl Kopaskie, who leads our women's health research, and Dr. Jeremy Miller, practicing OBGYN and SG2 fellow. We're going to discuss some of the biggest trends impacting women's health. So Karyl, if people just take away three things from the recent publication that came out, our 2019 forecast, and from this podcast, what are the three big things to take away?
I think really the three big things that we talk about with all of our clients are consumerism, how to do better channel management for women's health, as well as that infant and maternal mortality. So thinking about social determinants of health, consumerism, and how do we engage with women today?
Absolutely. And I think that we're seeing two different trends here, which are sort of informing that whole consumerism piece. The first one is declining birth volumes, that when we think about women's health programs, we've seen significant declines in total births nationally, and that certainly impacts how many women are coming through your organization. The second thing that we're seeing is gynecology services very different these days. We're seeing erosion of gyn wellness visits, and what that suggests is that women have different ways to obtain that routine care that women typically want to obtain. And that changes the nature of the relationship that women have with your organization.
It also changes who they're having relationships with, right?
There we go.
but it's women's health. Let's talk about it. We do have this idea, not only that physician relationship with women is so important, that the relationship with physicians are key, but we do see new entrants that are really trying to capitalize on different ways to engage women and build those relationships. We see things like apps or new market entrants that are offering better convenience, better service for women. I know the example we featured in the webinar of Tia Clinic, where patients are literally paying a premium to schedule appointments. It's not even that the appointments are included in the package, it's just paying for access. So knowing that these are services that are attracting women and these are the types of things that they're looking for, how can we modify our relationships with women to build and maintain that strong relationship that they want to have with their physician?
Right. Will Amazon be your gynecologist of the future? That, women have the opportunity to obtain services like getting contraception, birth control pills through apps. They can get screened for STDs virtually. They can get screened for precancerous lesions of the cervix virtually. Some of the services that we've traditionally required physicians for, women don't need that anymore. So that's certainly a change. And then the other thing that we're seeing is in terms of the kinds of services that women do actually come to the office for, they're different, right? Organizations are increasingly looking at subspecialty women's providers. So part of one of the trends that we talked about is declining birth volumes. The other piece of this is the baby boomers are aging, and we're seeing that middle-aged, older women need and can get different kinds of services. And I think that's really important because if you want to build out your women's health program, maybe you're not thinking about obstetrics so much anymore. Maybe you're thinking about how you're going to interact with younger generation through virtual offerings and what kinds of specific offerings you have for midlife to older women. And here I'm thinking about things like your gynecology program, things like your breast health program. And it's important because interacting with these older female consumers, let's face it, well more than half of healthcare is delivered to women. The success of your organization, and I'm not talking about your women's health program anymore, the success of your organization on an enterprise level really depends substantially on how you interact with that female demographic and how you can use channel strategy within your women's health program to direct patients to elsewhere within your organization.
I think that's a great point. And I know that is really the driving force behind so many of the questions. I would say one of our most popular questions that we get from clients is, how do I create that women's health program? How do I use that women's health program to better engage with that key patient population as a whole? And we see, especially in this kind of margin-driven world, that healthcare costs are really expensive. So thinking about different and creative ways to engage the kind of key decision maker, that's really what we see as being a driver behind a lot of this program development. But that can't be how you build a relationship, right? Like if we're coming back to what is the hospital's goal here? If we want to build a comprehensive program, we need to define what that goal is. Is it share? Is it capturing those downstream services that are well outside the traditional women's health world, like outside of OB-GYN and even breast? Is it thinking about how do we better capture those patients who will need inpatient services for themselves in orthopedics and cardiovascular care? Are we trying to build that more family style approach? Then maybe we need to be a little bit more diverse in how we're communicating these programs, because we need to be engaging her mom and her daughter at the same time. So if you're thinking about your women's health program as a front door to building relationship with a key demographic that utilizes a lot of services and makes a lot of decisions, being deliberate about how you're going to engage with them is going to be critical as we're building out those programs. And we hear that from clients across the country. Those programs that we see really, really succeeding in those comprehensive women's programs are acting with a deliberate goal in mind. They either know exactly who they're talking to, or they have a strategy that's driven over time to drive growth. So it's building out that wellness piece first to build relationships, and then adding in specialties that are target specialties for them to grow. Being deliberate about why you're engaging with women is really key. How do we engage? How do we build relationships? Being deliberate about it matters.
And let's call that out explicitly here. I didn't hear you mention doctors, and I certainly didn't hear you mention gynecologists at all. And I'm calling that out because that's important. That, as a practicing OBGYN, my interests and your interests as an organization are not perfectly aligned in this regard. That it's important for you to work around your gynecologist now to reach women directly. Whereas once I was a good source of referrals to your other services, to your GI services, to your cardiovascular services. That's not necessarily the case anymore. Furthermore, if I start thinking about my patients and the kind of revenue that I can wring from my patients over a given unit of time, and you think about the kind of revenue that you can get from my patients over a given unit of time. When I think about how am I going to make money as an OBGYN, I'm thinking about those services which are high dollars. So I'm thinking about pregnancy. I'm thinking about gynecologic surgery. You may not be. You may be thinking about older patients who may be seeing me once a year. My net return on a 55-year-old patient over a 3-year time horizon, it's certainly a 3-digit number, a few $100s over a 3-year time horizon. On the other hand, when I see a 30-year-old woman, I think, well, gee, she might get pregnant sometime in the next year or two. And for me, that's a big ticket item. So we think very differently about the kinds of patients that we want coming through our door. And while I may be willing to work with you, our interests are not completely aligned.
They're not completely aligned as they would have been in the past, but I really am sensing an opportunity here, right? Because there is, if we're not competing for the same dollars, we're just looking for an opportunity to both succeed, both capture that share, because we do see even in the OB-GYN market, and we'll certainly, as we get to social determinants of health, talk about those. The competition is fierce among physicians as well as hospitals. There could be opportunities for synergy. So the hospital's like, I can connect better with women because I have these resources, this platform, this program to use to help you drive volume, but also to help you get the right kind of volume. So if you want to be spending your time tackling those higher dollar procedures, what can I offer you as the health system that may take some of that lower acuity, maybe take some of that administrative burden, maybe take some of that channel engagement strategy, that time kind of foot on the ground building your reputation? What can I do to help support you build your practice the way you want it to? And then that synergy can help me down the road when you want to pass off that 55 plus patient.
Right. I think the flip side of that one is you can help me because you have the organization, you've got a bigger footprint. I can help you because I can be the kind face because, yes, well, on the one hand, some of this is transactional. Women are also looking to have trust. Mm-hmm. And even if some of the interactions are virtual, for some of the interactions which are charged in some way, certainly obstetrics is a good example, that trust is really important. Surgery is the same way, that you actually need a human being as the face of those entities.
Absolutely. And I think that thinking about that face, the health system can be a vehicle for your face to go to the community. So they can host the video platform. They can be that Twitter account, getting that communication out to the market. But I think you're absolutely right, knowing that it's still person to person. That's still what we see in the data. People form relationships with other people, not with companies and brands necessarily. So recognizing that you may not be relying on your physicians in the same way as you used to because the volume and your goals may be a little bit different. There are still opportunities for that work to come together. And I think that being open to evolution of that physician-hospital relationship as a way to both succeed with this increasingly consumer market is those are the organizations that will succeed.
And I think maybe this is a good opportunity to segue to talk about segmentation, right? Because the way in which we interact with our patients, who our patients are, that we want to come through the door, who are coming through the door, we have to think about how is it that you're going to appeal to those different patients who have different needs, and what needs can I deliver on as a physician, as an OBGYN specifically, what needs can other physicians in the organization deliver on, and how can you as an organization actually help me to do that by identifying what the different segments are in the market.
Honing in on that identifying, that is really where the health system has the advantage. And we have more data on our patients than ever before. We know that, yes, the transition to electronic medical records is cumbersome. It's still a headache. People are still upset about it. We get calls about that all the time too. We can't answer those questions. Don't ask. But what we do know is that we have all this data, and their opportunity to link that data with preferences and get a better sense of who our patients are in the market. That's an opportunity that's really on the table for health systems right now. And I would argue it's one that we're not really taking full advantage of the data and the information we have about our patients to be better about giving them what they need and communicating what they need to them.
Yeah. Why do you think it's so hard?
I think it's so hard because it's not a skill set that health systems are traditionally used to leveraging, where we don't necessarily invest in the data scientists necessary to really mine that data that we're collecting in a way that can then be translated to meaningful action for our strategy teams, for our marketing teams. And I think that those opportunities to really emphasize data interpretation and really thinking about it's not just data processing, it's data interpretation that's really going to make the difference.
That's not just a women's health or a service line issue, right? 70% of people said they'll use virtual health services.
Yeah.
But that's not what we're seeing. So we're still learning how to, okay, people said one thing on a survey, but then they're faced with an issue or a decision to make, and the decisions aren't always matching their survey responses. Yeah, we're absolutely at the very beginning of learning what to do with this information.
And I think that another interesting thing that came out of the consumerism survey that SG2 performed was that the expectation is there. We are very used to, especially in the US, we're very used to our information being processed, right? We read about it on the news all the time. Facebook knows everything about me and everything I'm going to do and everything I've done. So why can't my health system remember my family history that I've told them 40 times?
Why is it that it takes my doctor so long to get back to me with my test results?
Exactly. So I think that there's that expectation mismatch because we're being primed by the consumer landscape as a whole, that companies are leveraging data to know and anticipate their consumers' needs, but healthcare isn't using data in that way yet. And we do see that those health systems that are better able to integrate data information to actually synthesize, analyze, and act on data, those are the ones that are going to be able to segment their market better and really get to know their patients in a way that can help them to drive volume.
And we're really in the Wild West right now, that it's not as though we don't have an Amazon. I guess Amazon's interested in healthcare.
So is Apple.
Right, so is Apple. But we don't have a single dominant player in the field in this particular regard.
Right.
And in that sense, yes, it's a challenge, but it's also an opportunity because you're not getting squeezed by the Walmart or the Apple or the Amazon that's doing virtual health or market segmentation in the way that you'd like.
And I do want to call out that we are talking about something that is also very sensitive, right? The kind of information that a hospital is dealing with is very sensitive information. It's very valuable information, and it's very private information for our clients, not our clients, our patients. And thinking about how are we going to leverage this data in a way that's meaningful and truly take that opportunity to make connections with our patients and understand them in segments that are more refined than a woman aged 18 to 44, but also recognize that security is a real issue here. So it is something where there's a lot of opportunity, but there is also potential for security to be a real concern. So there is an opportunity, but it is something that needs to be done deliberately. It's not something that can be done in an ad hoc manner.
Yeah, I'm just waiting for the pop-up that says, do you have gonorrhea? We can help. Right, it's just...
Wait, you don't get that?
Okay, we need to talk, clearly.
Oh, yeah. It's amazing what the ads know about you these days.
For sure.
Changing course a little bit there.
On that note.
Another embarrassing fact here, the U.S. gets kind of embarrassed when we start to look at like national health stats. And one that's been front and center for a long time is infant and maternal mortality. Now, I know we're seeing some kind of hopeful work in that direction, and I know we've got to do some exciting local projects.
I think that just to kind of quantify the problem for those who haven't been reading the headlines, maternal and infant mortality rates, the U.S. lags, I think, in most of all of the kind of developed, quote unquote, Western nations in both infant mortality and maternal mortality.
It's not pretty. We're at the bottom of the list of developed countries.
And actually, the CDC just released a report that really just dove into maternal mortality in particular. And while that number is low, it's under 1,000 a year, but it's still too high for anybody's comfort. And the disparities that we see associated with those deaths are real and really revealing in the way that we deliver care to those underserved and at-risk populations within our communities. When you dive into that data a little bit more, there are opportunities on the clinical side, certainly, for hospitals to be deploying things like the safety bundles that ACOG has formulated, some of the work that's being done in California, some of those safety packets to really reduce some of the complications. We do see cardiovascular complaints, so hypertension as well as other cardiovascular concerns are a leading contributor to maternal mortality. So there are absolutely clinical steps that can be taken, and would strongly encourage all health systems to adopt those measures to really reduce the morbidity and mortality for women. But we are seeing opportunities to reach outside the four walls of the hospital.
We can start by looking at this at a very high level, that when states get involved in trying hard to diminish the rates of maternal morbidity and mortality, that it is possible to move the needle. And California is a good example of that. And likewise, when states aren't invested in just obtaining the requisite data, when they're not interested in developing programming, that we see maternal mortality and infant mortality rates go up. Mm-hmm. So it's not as though we have to just throw up our hands and say, this is the way it is because rural health is a challenge, because patients of low socioeconomic status are hard to take care of. We talk about social determinants of health. But clearly, when you take a high-level view, it is possible to have a significant impact on the outcomes that patients experience. And to your point, it takes action on a state level, and it takes action from healthcare organizations not working unilaterally, but working in tandem with other healthcare organizations in their communities, not just healthcare organizations, but other organizations that influence health within particular communities in order to move the needle.
And with the communities themselves. Trevor, you alluded to a project that we'd been working on. We were fortunate enough to work with the group called Westside United, which is a consortium of 6 health systems on the west side of Chicago, with the targeted goal of reducing the health disparities for those residents living in some of the 6 western neighborhoods of Chicago, where the life expectancy is about 13 years less than what we see in downtown Chicago. So big opportunity for some real quality of life and health outcome improvement through this consortium in a very targeted setting. And one of the things that we identified during that project was the importance of actually talking to women in the community about what they perceive to be the barriers and disparities in their own healthcare journeys. In addition to pulling in not just other healthcare entities and other healthcare workers and those community programs that do good work in those communities, but also taking the time to ask women themselves, what was their experience? What are the barriers that they felt accessing care? And I think we had some surprises that came out of those conversations. I know for myself, we had one of the complaints that was mentioned several times by different women within that conversation was feeling as though they weren't being believed by physicians telling them that they weren't pregnant. It took one woman 4 months to get a blood pregnancy test. She had to go back 3 or 4 times just to get a blood test to verify her pregnancy because her urine test kept coming back negative.
This is like the Serena Williams story,
exactly.
Right? That we have good evidence to believe that African-American women just don't get the same kind of prenatal care, not necessarily because of access issues, but because of the way they interact with physicians.
Right, and the way that physicians interact with them. And so thinking about when we're having those conversations, that was certainly one piece that came up, is really listening to to all of the stakeholders within the community, not just those healthcare stakeholders or not just the hospital-based ones, really getting that perspective from everyone to come up with that common solution.
What's interesting too, one of the things that I learned is just the extent to which we have granular data about what informs health outcomes for women in the setting of pregnancy. And when I say granular level data, we actually had data about, on a zip code level, regarding how easy it was for women to access primary care, how easy it was for women to access prenatal care, and who knew that we could get that deep down into the weeds about just what it was that informed outcomes. And as it happens, my recollection is that access to primary care didn't have an influence on a woman's likelihood of infant mortality, correct?
That's correct.
And whereas access to prenatal care did inform that very much. And while there's some degree of alignment between access to primary care and access to prenatal care, it's not perfect.
Yep.
And that's really surprising. Why is it that women would have ready access to primary care and not necessarily access to prenatal care? And it probably just has to do with the distribution of OBGYNs just across zip codes.
Right.
It probably also has something to do with patterns of transportation, again, on a zip code level, which is awfully specific. And that's the kind of thing that, yes, we talk about state level. Yeah, at the state level, we're interested in things like data collection and we're interested in protocols. At the community level, we're interested in some of these basic things like what's access to nutrition like? How easy is it to get to a clinic where you can get care and to get to a hospital where you can get care, or a hospital which is actually at an appropriate level of care to handle the clinical situation that you have? It's
really interesting that difference that we see, because we found that certainly data collection matters at that state level, and also information sharing. So coming back to that, how do we communicate and act on data? So similar to how we were talking about with consumerism and understanding and segmenting our patient populations, taking data, bringing it together, but then acting on it and being able to interpret and utilize it, that was the real key to some of the work that we were doing. So being able to identify from those metrics that were being collected by the public health department and incorporate that into clinical responses that could help to narrow the gap. So things like centering pregnancy, which could help to address some of those prenatal gaps that were identified in the public health data.
I'm sorry, centering pregnancy, Karyl?
Yeah, centering
Define.
pregnancy. So centering pregnancy, that is a product name for what it's essentially is group prenatal visits. So bringing women of a similar gestational age together in a group setting to have their prenatal care delivered by, I believe usually it's a nurse practitioner or a nurse midwife level provider. And the idea there is twofold. One is it helps to extend resources. So especially for those places where access to a provider could be really challenging, and having that visit conducted for multiple patients at once can be an efficiency gain. It also helps to build communities. So we also see that there's opportunities, and this is something that, again, came out in the conversation with the women in the community, is that while women may not necessarily sign up for a support group, even if they need it, by putting them in situations where they kind of organically create communities of women. It's functionally a support group. Right. So there's that opportunity not only for women, for a health system or a health entity to spread resources more to a wider group of people. It also organically creates communities to help people stay accountable. So stay accountable to nutrition goals, stay accountable to attending visits, because there is that community aspect to the care. Right. It is sort of mind-bending, right? That on the one hand, we think of health information as being next to financial information, right? Being the most sacrosanct thing that there is. And yet here's this model which has been demonstrated to improve outcomes, which is entirely contingent upon completely breaking down that wall about privacy of health information. Absolutely. Which is, it's certainly a crazy thing. I guess the other thing, as long as we're having this conversation about novel models, what about virtual care in the setting of high-risk OB? Yeah, so we're seeing a lot of effort in this space. And here again, we have some health systems really diving into this and trying to leverage that data. But we also do see some outside entities wanting to enter into the space as well. We know that if you look in your application library, there's over 3,000 birth-related tracking apps associated that are being pushed to moms today. But we do see, especially connecting some of the remote monitoring, so things like looking at monitoring blood pressure at home. So a mom can have a remotely enabled blood pressure monitor, a remotely enabled scale to monitor those kind of vital statistics in the comfort of her own, but also getting more data points where she may be in lower stress environments, for example, to get a better sense of, are there concerning trends? Are we beginning to see early indications of preeclampsia that need more attention now? And being able to interpret that data through the app that the physician is interacting with and proactively beginning to manage those patients who may be at risk for things like preeclampsia or other conditions.
We're talking about blood pressure here, and we're also talking about a clinical entity, which is a major cause of maternal morbidity. I know it's just a blood pressure cuff, so how complicated can this be? Well, the answer is what's really complicated is the organization that surrounds it and not the actual acquisition of the piece of data.
Right. You have this opportunity to collect a lot of data in real time from the patient, and the app helps to facilitate that data information aggregation and analysis to push to a physician, hey, I think you should look at this because the numbers are beginning to move out of range. And then the physician can act on that information and make the clinical decision about whether or not that patient should be brought in for a visit.
I think the other piece when we think about virtual health here is we're talking about social determinants of health in urban environments. Virtual health is also, and telehealth is also an important tool if we're talking about in rural environments, because the issue with maternal mortality, and I'd have to check on the data, but infant mortality may be less of an issue there, is in rural environments, it's very hard for women to get good obstetrical care. There are lots of counties in the United States which just don't have a provider. So having a telehealth relationship so that women can see perhaps a family practitioner or perhaps an OBGYN, but if they have a high-risk condition, can have a telehealth relationship with a provider that's remote is also certainly a valuable tool.
And we did see, I think, in the last Society for Maternal Fetal Medicine conference, one of the posters there did highlight a text-based telehealth application focusing on the postpartum space. Since we know that a lot of those risks for mom do arise during the postpartum period, this was a text-based application that allowed patients to check in and give feedback. And just that engagement piece that was facilitated through the virtual platform was able to help support that higher risk population.
Yep, absolutely.
And when we're talking about rural, I've heard organizations trying to focus more of their development on text-based applications because of broadband challenges.
Yes.
Instead of letting that be a crutch, great. One, text is easier for patients and it's just less cumbersome. And that you don't need a video interaction to have a quick exchange and build a relationship. We covered a lot of ground. Talked about many big trends that are impacting women's care. But did we miss something? We heard a recent story from an organization that's trying something new or seeing something different, or a market that's moving maybe faster than the rest that you want to highlight. Maybe it's not the trend that's going to impact everyone this year, but it might be 2 or 3 years down the road.
I got one. You got one?
You got one? Okay, go ahead. You can go first.
One of my kind of favorite lessons learned ties some of these themes together, because I think when we think about social determinants of health, when we think about some of those channel strategy and consumer engagement, it does all come back to relationships and trust. And I was working with an organization earlier this year that really did a phenomenal job knowing who they were as an organization, so having a very clear organizational vision and purpose and identity, and allowing that identity to really permeate all of their interactions with women. And I think the one way that was best exemplified was through some of their support groups. So they actually found that with their lactation support group and with their breast cancer survivor support groups, they were able to draw patients from some very high level, high brand name recognition organizations in their market to the kind of the community health system just through the power of those relationships and that kind of personal touch that was kind of the living embodiment of their organizational identity. Having a clarity about who you are and who you want to be to women, and then kind of living that through different programs that you develop, clinical and that non-clinical side, can be a really good way to build that trust with your market long-term. So I think that was a really fantastic example of an organization who really embodied who they wanted to be, and women in their community trusted them because of it.
It seems more and more when we talk to organizations, they're really focusing on specific programming for midlife women, whether we're talking about breast health navigators, or screening and diagnosis and management of breast health conditions, or urogynecology is really the big one because the volumes there are so substantial. So here's an opportunity for OBGYNs, that's the kind of doctor that I am, to engage with women and provide care to a population that wasn't getting care in the past. It's also a growth opportunity, which is good for hospitals, and it's also a population that organizations more broadly at the enterprise level that they think is important. Whereas OB used to be the focus, I don't think that's really true anymore necessarily. And that isn't to say that those issues we were talking about before about social determinants of health, and we barely touched at all upon the prevalence of morbidity in the obstetric population, which is a really big deal. But
also in the GYN population.
And it's true in the GYN population too, but that organizations are thinking when they're on an enterprise level about engaging with that midlife woman because it drives the organizational bottom line in a way that OB doesn't. And yes, OB is absolutely important, but it's a different kind of transaction.
For sure.
Dr. Miller, Karyl, thanks so much for sharing your perspective with our members. If I hadn't gotten in the way, I might just let you keep going here, and I'm sure people would love it. So
we have heard that we're a little chatty.
You'll have to agree to do episode 2 at some point down the road.
All right. Thanks, Trevor.
Thanks, Trevor.
Okay. Thanks, everyone. Have a good one.
Thanks so much for joining us today for this episode of SG2 Perspectives, where SG2 experts and industry thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. I've been your host, Trevor Durin. Contact us anytime by sending an email to sg2perspectives@sg2.com. SG2 revolutionized demand forecasting with the Impact of Change forecast in 2001, and today we're the healthcare industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks for tuning in. Hope to see you again soon.